How long do implants typically last?
I mean, we say to our patients they should last your lifetime.
Right.
The question is, why would they fail?
Right.
If they're really good and they're done perfectly, they're still failures. So there's another big question in the dental community, and it's a real question. And I'm going to be honest with you.
The patients who want implant dentistry the most are the patients that are most unhealthy. They're knocking on the door wanting to do it today, but they have neglected to take care of themselves throughout the years.
If you have to get crown lengthening and it's sacrificing bone, well, after you get a root canal, that bone is worth more than the tooth.
Yes.
Yeah.
So if you have to sacrifice bone to keep the tooth, that's where you have to stop and say, is it worth it?
Yeah, and then there are these cases that patients have 6, 7, 8 teeth. They look healthy, but they're really compromising.
Talking Teeth with Dr. Dean.
Welcome to Talking Teeth. Hello, everybody. We're here again. Sorry for the little lapse of episodes, but we are back talking about implantology and implants, dental implants, that is. We want to talk about what they are, how you can get them, how much they cost, what are the benefits and risks about dental implants, and really what's going on in the new technology with dental implants. We have our favorite cast of characters, Dr. Publio Silfa, man of the hour. We have Superwoman, House of Conchetta, Becca Morris, and we have Lokesh Rao, an amazing implantologist who spent a lot of time with us here in the office and in the Dominican Republic, where we had our beautiful course where we all were down there helping Dominican people. So let's just get it off. What are dental implants? They're titanium-based replacement of a tooth. It could be a replacement of a single tooth, multiple teeth, full arch of teeth to get patients back their natural ability to eat, to smile, and to function. So let's start it off, Dr. Publio. What types of implants are there? What's available today? Tell us about your perspective.
Well, from my experience, there's so many brands of implants, but they all have a specific use to rehabilitate or fix or replace a tooth. So, for example, there are zirconia implants. There are implants that are used more for full mouth reconstruction because of the connectors they have above them. And there are implants that have all the connectors in one, for instance, like the screw and the abutment. So each implant has its place in its use in the hands of the professional.
So how does a patient know? Obviously, they have to, they're missing a tooth, or maybe they have dentures or partial dentures, and they want to get to an implant dentist. Is there a specialty? How do they really know this dentist in particular is qualified to give them an implant?
Once again, I always tell my patients, if you're going to consider a second opinion, look into the patient's doctor's credentials. Where did they go to school? How many implants have they placed throughout the years? And also allow them to show you what type of implants they're restoring. When you get to see a patient or a picture, you're able to identify as a patient, oh, I actually like how this looks. It looks very natural. It doesn't look artificial. He has all the setup to do a digital implant, or even he has his own lab. So when you have an experienced doctor who has placed numerous implants throughout the years or has credentials, he's a diplomat, he's an oral implantologist, like he definitely is someone who's placing implants at a higher level than the average dentist.
I will say that,
as for you, I mean, we know you had your implant. How old were you when you had your implant?
so I was 18, and I will say that it really made a difference seeing the before and afters that the surgeon had done previously, choosing. But I was 18. I had lost this.
How did you lose the tooth?
I was just born without the adult tooth.
Oh, yeah, anodontia. That's called anodontia. Some people are born without certain teeth. They didn't necessarily lose them, and that's called anodontia, and that's what happened.
Apparently, it's really common.
Very common for lateral incisors. Yeah,
and sometimes the baby tooth just won't fall out because there's not an adult one pushing on it, but mine did when I was young. So I had a fake one glued onto my retainer, onto my braces. It would chip off when I'm eating at lunch. It was so embarrassing.
So that's a self-conscious situation.
Oh my God, it was so bad.
But the amazing thing that you had the opportunity to go through the right process to get an implant.
Right.
So you had orthodontia, and the orthodontist understood that it needed to be a specific space
right.
for the implant, right? Because at the end of the day, you're not looking for an implant. You're looking for a tooth. You're looking for a smile.
What do you
that's
think?
Where,
The question that becomes, a lot of big questions are, how old or how young can the patient be to get an implant? So I've had my personal experiences early on in my career, and I tell you, we made some mistakes because we put the patient who was too young, we put the implants in when they were too young, and that became a problem in the course of their life. Dr. Locke, what's your number, the youngest person or the oldest person? What's the range for you?
Usually we say when the patient's done growing, but you really don't know when some people are done growing. So I pick a random number where I know, by this time they're pretty much done, and I go with the age of 25.
25. So that's our age as well. Anybody less than that, is if you're missing a tooth, the recommendation is to get either a little bonded bridge or some kind of provisional that can last them until they're 25, because sometimes children lose their tooth at 17. So we can do some kind of bonding provisional, something to look good, that's kind of in their mouth, it's fixed, it's not coming in and out. The removable things that we used to do in the past, we get away from that. It hurts the bone, it hurts the tissue, it's bad. So we'll always recommend a bonded type of bridge. And then when they're 25, they can start thinking about implants and replace it. So the other question comes, who is a candidate? What do we need? What's the requirement to be a candidate for implant? Because not everybody can get implants. So what's the requirements?
In general, obviously the best health can't always control what our body does. There are certain conditions like diabetes. If you're on antidepressants, they can prolong treatment time. So make sure you just tell your dentist.
Smokers also, if you have smokers, it's going to give you a decreased amount of success. So we always disclose that to the patient. If you're smoking, diabetes, or any kind of high blood pressure health issue, you're going to have a decreased chance of success.
even taking medication for your bone, osteoporosis medication.
That's
How long
big
do
one.
implants
That's a big one.
typically last?
I mean, we say to our patients they should last your lifetime.
Right.
The question is, why would they fail?
Right.
If they're really good and they're done perfectly, they're still failures. So there's another big question in the dental community, and it's a real question. And I'm going to be honest with you, we don't know what happens sometimes. What my feeling is, looking at patients over 35 years, their body changes. There's a change in their bone levels. There's a change in their health. They change their medication.
Medications change.
And then the bone structure, where the actual titanium is fused to the bone, that fusion starts deteriorating.
Yeah.
So those are some of the reasons that
It's interesting that you say that early in your career you made mistakes, but you also saw the trend of what was happening with implant dentistry when you started too young. Right. In my experience, I've done many arches, where like, why am I not giving the patient the opportunity for a future revision? Because I've noticed it. There's always going to be one failure. There's always going to be recession on the threads. Something will or might happen. But I always want to give my patients, the expectations or the opportunity to upgrade or to revise it or transition to a better type of dentition.
And we're doing that right now. We're saying to our patients, whatever age they are, we're going to probably get this prosthesis, this implant prosthesis, these teeth, to last you about 15, 20 years. Yeah. What's going to happen after that? Not necessarily have to replace the whole thing, but maybe one or two of the implants fail and I have to replace them. So there's kind of a revision, an upgrade, like you said.
It's like a hip surgery or knee surgery. Right. You're always going to go back to a hospital and have a possible revision.
Right.
It's nothing lasts forever. Nothing is definitely.
How much do they cost?
Cost a lot of
money. Well, I was young, so that was on my parents.
Parents paid it. So implants are expensive. Obviously, it depends. It can range from $1,000 an implant up to $5,000 an implant. Sometimes $8,000 an implant, depending on who's doing it, depending on the expertise, depending on the type of implant. Which clinic are you in? Are you in a certain area of the country? It's very inexpensive. Another area here in Manhattan, it's very expensive. So
so the
cost is a lot. And then you have some insurance sometimes pays for some of the crown or sometimes. But it's a real issue for patients. I mean, it's definitely an issue that we have to deal with, either financing or spreading out the payments over time. The thing that I think is very important for patients to understand is that you want to get the right treatment and then figure out the finances, as they go. But you have to get the right treatment at the end of the day. Otherwise, if you're compromising the treatment, let's just say you need 5 implants, but they only can afford 3 implants. Well, don't do just 3. You're going to make a mistake on that end, which happens a lot. Patients can only afford this much, and then the dentist or the professional compromises, and then at the end, we get the patient, everything failed because they didn't have the right distribution of implants. So that's not good either.
The other issue is if there's any pre-surgical or pre-implant grafting that needs to be done.
Okay, so let's talk about that for a second. Some of you may hear the word bone grafting, bone augmentation, sinus lift augmentation. These are all procedures to add bone because you can't put the implant if the bone is not there. If the implant's 4 millimeters long, you have to have at least 8 millimeters of bone. So you have to have enough space to get that implant in.
Yeah.
Some people lose the tooth and they don't have enough space. So we have bone grafting. Talk about bone grafting.
So the bone graft is just the preparation of creating the surface or the place for the future implant. Sometimes we don't have that. We had an extraction. Unfortunately, the patient had lost the entire buccal plate or buccal bone. So we have to build that with the matrix. And there's different type of bone graft in the market. Some doctors are using PRF. Some doctors are using cancellous bone. And it's just trying to find what's the best fit for the patient's site to rehabilitate that area.
Right, because you can also have one implant that goes in on the left side, perfectly good bone, and the same patient on the right side, there's no bone.
Yeah.
So it's not even patient specific, it's actually site specific.
Site specific.
So you can have a successful implant on this side, and on the left side, the bone was terrible, and they lost the implant, and they have to redo it. So people have to understand the body is a very dynamic place. And when you talk about bone and healing and tissue, when an artificial screw is going in, that's what's happening, the body's got to be able to heal that. And again, each side of the body is different. It's just different, and people don't realize that sometimes. Yeah. And then the other issue is you need a surgeon that's a good implant surgeon. You need a surgeon that knows how to do bone grafting. And then you need a dentist who knows how to make a tooth. That's 3 miracles that have to happen to get this thing to work.
And
Right?
that is one of the biggest challenges patients have. When patients come to me, it's like, oh, do you do just the surgery or you also do the crown?
Right.
You know, fortunate and I'm capable of doing both.
Yeah.
Right.
But sometimes they have to see the oral surgeon. They have to walk out of the office without a tooth.
Without a tooth.
That's what
They
I
have-
did, yeah.
They have
Yeah.
to be without a tooth for weeks or months,
And
then they have to
sometimes
come
that's
back with
okay.
it.
It's just again,
Yeah.
depends on the site.
Yeah.
Dr. Locke had a lot of experience, and what we're talking about is placing the implant, but then actually making the tooth. The other miracle, it's got to look beautiful. Look at your tooth. Your tooth has to look beautiful. That's why we met again. We went and restored that, and we fixed it for you.
Yeah.
So aesthetics in the front area becomes a huge issue. Our anterior implants are probably the most difficult implants to make look beautiful. So when a patient comes in and says, I want an implant in the front, I'm like, wait, maybe you don't want an implant. Maybe we'll do a bridge, because I can guarantee aesthetics on a bridge. I can't guarantee aesthetics on an implant. There's too many variables. Your implant all of a sudden got gray after 10 years. Perfectly good implant, looks okay, got gray. Why did it get gray? The body changed, you're still growing. Beautiful young woman, you're still growing. And all of a sudden, you got gray showing through, which the bone receded. And there's ways to fix all these things. The good news is we have great specialists who can fix things that go wrong, and that happens. So let's talk about when a patient is missing all their teeth, if they're a denture patient or they're losing all their teeth. There's a concept in the dental world called all-on-X, right? We're completely fixing every tooth with 6 or 7 or 5 or 6 implants. The all-on-X is a very big deal in America. I think personally it's an overkill. I see patients who have perfectly good teeth and they're being ripped out and also all-on-X is replaced.
Yeah.
Not to say the all-on-X is bad, but these other ways to fix the teeth. But let's just talk about what's happening in the country. What do you see the trend going on? The materials, the technology. Let's talk about that for a second.
Well, I'm going to go directly to what I've been seeing on articles in the newspaper. You look at it, everyone's talking about the dental implant specific type of centers, and they're being sued by patients who have not been receiving the care that they expected. Now, these centers are only looking at dental implants or patients to get dental implants. But if a patient has all 8 healthy teeth and all they need is a sinus lift and 2 implants and sinus lift on the other side, that's it. The patient could easily get restorative dentistry, get crowns, and 2 or 3 implants.
But do you think that's a lack of information, a lack of experience?
I might get some fire for this, but
Tell the truth.
We love it.
what's happening is that there's a lot of corporates involved in this. So there's a lot of big money.
Right.
So when you have a center or practice that in 2 hours could do the implant surgery, walk you out with teeth, and save the day for that procedure for that patient, you're actually taking advantage of the patient's opportunity to make money. And then all of a sudden the business is making money, and the return that corporates are getting is 30, 40%, right? So they're making a better investment in the healthcare industry, and then over time, the patients are suffering. Because what these centers are doing is reducing all the bone, removing everything that's possible, and delivering.
And there's no second chance.
Well, that's the thing.
They come to us, and we have to fix them. I mean, how many times does that happen?
They'll come back.
Yes.
But
Oh, wow.
In our practices,
Yeah.
ladies and gentlemen, in our practices, I think we're very high-level individuals, and our expertise is very high level. We trained for 20 years, myself 35 years. We have to fix a lot of problems. That's a heartache for me to see a patient spend $20,000, $30,000, and I got to spend another 40 to fix it.
Yeah.
Wow.
And
That's a problem.
that's what it is. There's a plan A, plan B, plan C. And what happens is that they are all jumping to plan C.
Right.
Immediately. Get implants all next. Hey, what happened to bone graft? What happens to crowns and bridge and veneers and root canal? Let's save this dentition.
Well, that's the other question. Save the tooth or take it out and put an implant? That whole conversation is a daily conversation. Do I save the tooth with a root canal post and a crown? Or no, take it out, we'll put an implant in.
At the end of the day, I tell my patients there's nothing better than what Mother Nature gave you.
Nothing
or
better
what
than
God
natural.
gave you. If you can save the tooth without compromising the bone, do it.
Yeah.
Hands down. If you have to get crown lengthening and it's sacrificing bone, well, after you get a root canal, that bone is worth more than the tooth.
Yes.
Yeah.
So if you have to sacrifice bone to keep the tooth, that's where you have to stop and say, is it worth it?
Yeah, and then there are these cases that patients have 6, 7, 8 teeth. They look healthy, but they're really compromised. And I get it. At that point, that's when we have to make a decision, because it's not worth trying to save a tooth that's very hopeless when with implant dentistry, you could get very close to natural. And then that's where I come in with the All-on-X, which is 6 implants, 8 implants at times. What I'm now doing is sectioning the aesthetics of natural looking teeth over implants. Let's talk about this patient in 20 years from now.
Right.
If one of those 2 implants were to need to be revision, I'm able to upgrade them, replace that, graft it, put a provisional, because I've already have all the files digitally scanned as a patient of record, and I'm able to give the patient a better experience throughout that. If I'm immediately taking out all the teeth and putting implants, or as a matter of fact, they're going directly to the cheekbone, right?
Zygomas,
They're
yeah.
going to the zygoma and placing those implants there. You know what happens when they fail? There's no more options. There's really, really very limited option. And that's where it becomes more expensive for the patient. The patient was not educated, did not take the proper education to make that decision. So always sit down with the dentist and look at the options. Fast forward what you're getting today and look at what would happen in the future if you were to do it again.
Yeah. Another big thing is the digital capabilities and the technology that allows us to do what we do. So a question that I would have for the patients is, make sure your dentist has a digital platform. To have that means that they have photography, they have scanners, they have facial scanners, they have a CBCT scan that takes a whole, X-ray of your whole head and your whole, to really know the density of the bone. Because I could have all the bone I have for implants, but the density is not good. Talk about vitamins and the medical markers that allow patients to have a good bone. What's the medical markers that we use?
Some of the common trends that we look for are vitamin D levels. If your vitamin D levels are low, then your bone metabolism doesn't work as well.
Right.
And I've seen catastrophic failures from...
What's the other calcium marker?
A1C?
A1C.
That's diabetes.
Oh, the
HbA1c.
Okay. And some of the medical things, such as A1C, talk about that.
Well, if a patient's primed for surgery or in a good position to have surgery done, their HbA1c should be somewhere between 5 and 7, especially if they're diabetic. Anything above that, you want to wonder, are they controlled or not? And if they're uncontrolled, they have a higher incidence of failure in that first year. So you're going to want to delay loading those implants for up to a year,
You know,
especially if they have uncontrolled diabetes.
I'm going to say this. The patients who want implant dentistry the most are the patients that are mostly unhealthy. They're knocking on the door wanting to do it today, but they have neglected to take care of themselves throughout the years.
Yes.
High blood pressure. I had a patient sit down in a chair. Sugar was around 200. Blood pressure was 180 over 110. And the patient's like, "Doc, start now." And I'm like, "No, I cannot. Look at your records. This is your baseline. When was the last time you went to the doctor?" "I haven't been in 2 years. I didn't take the medication. I'm taking my mother's medication." I'm like, "What are you doing?
Oh my God.
What are you doing?" So he comes back. I said, "Listen, go take care. Go to the urgent care." He doesn't come back for like a week or two. He calls me at the office. He calls the girls, and he says, "Tell Dr. Silfa that he saved my life." And I'm like, "What happened?" I didn't even touch him.
Right.
But the fact that I took the initiative to send him and refer him to the emergency care, he says,
medical health.
he says that night he went to the emergency room, because he couldn't make it to the urgent care, and he fainted walking into the emergency room. Immediately they took care of him. He was in the hospital for a week, and they got him back to a good baseline.
Medical health, ladies and gentlemen, is super important. We're doing surgery, whether it's 1 tooth or 10 teeth. We're doing surgery.
Yeah.
Okay? Whether they're on Coumadin, they're on different blood thinners, they're on high blood pressure pills, they're over 60, 65, 70. You got to check the medical history. That happens all the time. I hear stories all the time. The patient is not healthy. It's not time to take out 4 teeth. The patient's 85 years old. What's your oldest implant, age-wise?
95.
Mine's 88.
92.
92. Okay. So if they're older, it's fine, but they have a good baseline history. Hey, no problem. Put the implants in, right? But a lot of them are not healthy, and it's dangerous.
And that's why patients ask me, "Doc, why do I want dental implants? I'm not going to live that long." And they're like 80 years old. And I'm like, "I just placed an implant on a 92-year-old last week. What are you talking about?"
The other thing is, I always tell the patient this: do it now when you're healthy.
Yeah.
You don't know how long.
Yeah.
My mother's 93. I got her implants in at 75. She's got all her teeth. All her other friends got no teeth.
Yeah.
She's 93.
Wow.
So do it when you're healthy now, even if it's for 5 years. Just get your implants in now that you're healthy. If you're not healthy, then that's a big thing.
You know
for
what's
us.
the common thing they say after they get their implants, after the age, they say that at 80 they get implants? They always say, "I wish I would have done it
earlier."
sooner." Right? And I'm like,
You had a
yes.
question about pain.
The pain. Yes.
So let's ask you. You went through it. I don't have had an implant. How does the
So
pain
for
feel?
me, it wasn't that bad.
Okay.
The recovery. I mean, I was young, so I don't remember. I don't think I was fully under.
Right.
It was just local.
Yeah, we do local. Pretty much
Yeah.
all the time.
And it was quick. It was like an hour or two, and I woke up and felt fine. It was just the healing, and I had to go to someone separate to make the
Make
tooth.
the tooth, right.
Yeah. Yeah.
But the pain, when people ask us how
was
painful
not.
is it, I usually tell them it depends. It depends if you're swelling. So we like to tell patients after their implants, a lot of ice for 2 or 3 days, some ibuprofen, some
Yeah.
kind of, inflammation reducing drug, and usually they don't have pain.
Yeah.
The ones that do have pain, either one, don't put the ice on, didn't take the medication, didn't follow the rules, and all of a sudden they're swelling up.
Yeah. To me, it's a mix of both. I always tell my patient, "Doc, am I going to be in pain?" And yes, you'll be uncomfortable. We're doing a surgery where if you're not in pain from the incision, you're going to be in pain from the numbing. There will be some discomfort.
Yeah.
But every patient is different.
Yeah.
I have patients who swell up from 1 tooth extraction, and I have patients that I do a full mouth rehabilitation and implants and extractions, and they didn't even take a Tylenol.
Yeah.
So I look back at the medical history, and I'm like, all right, so all those unhealthy patients who are not following a balanced diet, who are eating cardboard boxes or not eating whole foods, those who are not eating well, they're pain, they're swelling, they don't heal immediately.
Yeah.
Patients who are super healthy, had that life change,
Yeah.
they're healing like that.
Yeah.
What happens when an implant is placed and it's in the wrong position?
Oh.
And they come to your office. She's like, They come to your office. They come to your office and they say, Doc, I put my implant in. I had it done by the surgeon. He told me to come to you. I need you to restore it. What's your conversation there?
You can redo an implant.
Well,
Yeah,
That's an extreme. That's an
Nice.
extreme. So
Okay.
the first thing we look at how the implant was placed. Is it too close to a natural tooth? Is it too close to another implant? If it is, then you're going to end up getting bone resorption or loss of bone in the end.
and then at the end, you're responsible. If you actually make that tooth, you're now responsible for
Exactly.
that tooth, even though you didn't place it. That's
Exactly.
a big legal issue for us as dentists, right? The patient comes in, he's got 2 implants, they're in the wrong position, so I have to make a decision. If I treat this patient, I'm responsible for
You're,
the tooth.
you're owning it. You're owning
Oh,
it.
okay.
I own it.
You're taking.
You put the
Full
foundation in the
responsibility.
house, I'm building the house now, make it look good, and then the foundation's not good. Well, if the foundation breaks, the whole house goes down. So now I'm responsible. So talk about that.
Well, when we see how the implant's placed and the angulation or where it's coming out of the bone, we make a decision on whether one, it's restorable by conventional methods, for like meaning like a stock abutment, a pre-made abutment, or we can get the lab to make what's called a custom abutment or an angled abutment, so that the component that the crown sits on goes in the right plane and doesn't stick out like a sore thumb. But that limits how we insert the crown. It could be either cement retained, meaning we put the little glue in there and pop it in, or we have a screw that goes into the crown.
And how does the angulation affect the aesthetics when they look in the mirror and they say, oh, that's my tooth, looks great, or it looks a little funny, right? Because the angle was off, what you started with.
Yeah. So a lot of it also depends on the tissue type. If the tissue type is too thin, it'll show more.
Right.
And then how you color the abutment. I'd like to gold anodize my abutments in case there's a thin tissue type.
What about maintenance? How do you take care of your implant?
I just take care of it as a normal tooth. I
you have
floss, brush.
Because you only have one.
I only had one,
Right,
and I've
right.
had it since, I was 18. So.
Yeah.
I've
But you're
always-
basically flossing and brushing.
Yeah.
What if they have multiple implants? What's the best way to clean them?
I always tell them that they will have to come in for maintenance every 6 months. We recommend them a water pick. The moment they start the process of implants, they get a water pick. And I tell them that it's like taking care of a car, maintaining a car. In 6 months, in 2 years, we go ahead and we remove the actual arch or teeth and put them through the ultrasonic, clean it, and change the screws. So we kind of like changing the tires after so many miles. We're changing that, debriding, and the patient has a better, healthier tissue.
What about proxy brushes? We like
No
proxy
proxy brushes. I do not like them at all.
I like them.
No, I do not like them.
Maybe
because
you.
What's a proxy
my
brush?
so a
Proxy
proxy
brush-
brush is a brush that
He
looks
doesn't
like
use it. He shouldn't be describing it. He doesn't use it.
No, I know what it is. The
Put it
reason
in
I don't
bad
like
light.
it is that a proxy brush has different sizes. So there's an extra small, small, medium, large, XXL. So what ends up happening is that the patient starts using the small one today, and as they continue over time and years, the hole in the access hole where they're digging,
That's the pipe cleaner looking
Yes,
thing?
like the
Okay,
pipe cleaner
The
okay,
baby
looking
bottle
okay.
brushes.
by the
Yeah.
time a year goes by,
like
they're already
those.
using the
They-
largest size.
You know
They
what?
make my gums
They're
bleed.
using it. That's the key thing. They're using
But they're
it.
traumatizing the tissue so
Not
big
always.
that
Not always.
I've seen it, and that's my reason.
You're in between.
I think the problem is people aren't properly, trained on how to utilize
trained.
it, and
Bottom line, it's got to be clean.
yeah,
Whether it's water pick, proxy brush,
Yeah.
flosser, you got to clean it.
you got to invest your time and money and.
The other thing is,
yeah.
this happens to all of us. Patient, we did the implant, it looks great. Patient's happy, they're eating. It's 2 years later, the screw gets loose.
Yeah.
What do we do there? I mean, everybody has their own tricks. How do you tighten the screw when the screw gets loose?
Yeah. Tell the patient you have to come into the office immediately. Cannot let it
My-
go.
My
Go
favorite
by.
is, how long has this been loose?
It's been a
Oh, it's
month
like
or
a
two.
year.
Yeah.
Oh my God!
yeah.
And if it's loose, there's food in there like a garbage can.
Stop!
And
Yeah,
now
so-
I gotta
Gum and
I gotta take the whole
One-
thing off,
One.
put the healing screw back.
Yeah. One of the biggest motivators to do change is pain. There's no pain. There's no motivation. to
Yeah,
go.
oh, that's
If
true,
you're
yeah,
missing
yeah.
your front tooth for an event or something, there's
Right.
motivation.
Me last
Right.
night.
You know?
They had to fix my tooth this morning before this filming session, by the way.
He's like, what the fuck is going on here? What's going on here on a Saturday morning? Everybody involved.
You might have to file off the super glue I put on it.
Oh my god.
Good news, I'm left-handed.
Oh, you are?
Yeah.
Oh, wow.
Good as new. Right as rain. There we go.
So that's usually the motivator. There's no motivator to pain or change.
Yeah.
There's no reason for them to come in.
Oh, that's a good
and that's
point.
where you have to educate them. That's where the warranty comes in.
Yeah.
I guarantee my work, right? I have a 10-year warranty of anything that happens with the implant.
Right.
But you have to be committed to every 6 months.
They have to
coming-
be committed.
coming.
That's a big thing about maintenance. We can guarantee our work if you're here every 6 months. If you disappear for 3 years, I don't know what happened. I can't guarantee the work.
Yeah.
Another thing that happens, going back to the patients, if they're not in pain, implants have no nerves. So once they have their implants in, they're very comfortable. They're eating, they're doing their lifestyle. They don't even think about it. They just love their teeth. Sometimes there's what's called implantitis, periodontitis. If they don't come in every 6 months and we don't take that x-ray, I can't evaluate what's happening underneath. Your screws could be broken, your implants could be failing, the tissue is all infected, and they have no idea because there's no pain.
There's no pain.
So the 6-month protocol is mandatory in our office. So I could take an x-ray, oh, you may be losing some bone. Maybe you're not cleaning this area. Let's save the implant. I had a patient 2 months ago. She had her implants done 28 years ago. Guess what? Her husband's a dentist, so she feels safe. She goes for a cleaning once every 2 years. Nobody's taking x-rays. She lost 50% of her bone. Not in pain, just bone loss and threads exposed. And I'm like, what are you doing? And the doctors, her dentist, her husband said, don't you take x-rays of your wife? So this maintenance is a big deal for them to hold on to the thing that they spent all this money on.
Yeah, it's true.
Going back to the maintenance discussion, what I do is I put my patients on a 3-month recall initially in that first year, and the hygienist and I both evaluate them to make sure that they're cleaning their implant.
Because all the problems happen the first 2 years. And that's a good protocol.
And from that point, we decide, can they move on to a 4-month or 6-month protocol?
So I know implants are a component of smile design, but what is smile design and how can it, improve my overall health and my
You know how
aesthetics?
smile design changes your
But
life.
from a health standpoint.
Health standpoint, does smile design change your health?
Yeah, mental health.
Oh, mental health. He tricked us. Mental health.
That's one thing I'm very passionate about smile design, right? Because it's the blueprint of where I am directing the treatment. So in my office, every patient that walks into the office, they get the experience of getting pictures and video. And they're like, wait, this is different. We're getting pictures and video on day one because they're getting a 2D smile design immediately.
So you can show them what an implant will look like.
We will show them what the smile will look like.
Wow.
Even
They
though the
don't
implants in there.
Remember,
Including
patients.
the implants.
Yeah, remember, patients don't walk in, I want implants.
Right.
They're saying I want implants because that's what they saw in the marketing or the ad, but what they really want is a confident smile.
Okay.
So that's when we start the process of a smile design. And identifying a dentist who's just placing implants to restore them, then the dentist who's planning them in the right position to nicely place the implants to then give the patient's teeth. That is the best way to approach an implant placement.
Okay.
From simple implant, from one, imagine they would place your implant and your screw would have come out from the front. You would have had like a silver screw coming out from the top, right? And that's what we were talking about. What happens when the implant is not properly placed?
Right.
So if you plan the first implant to be ideally, great. Imagine doing this full set of 10 implants or 10 teeth with implants. You have to place them in the right position, and that comes with smile design.
Well, I think we've covered it all. We learned a lot about dental implants. Make sure your dentist is capable, has experience befores and afters. Make sure there's digital smile design and some kind of technicality and technical ability so you can view it beforehand. Make sure there's planning. Make sure you get maintenance over the next years of the life of the implant. And I think the main point is be healthy.
Yeah.
We have to be healthy
healthy.
so we can take advantage of all these new technologies.
I wanted to ask one more question.
Okay, go ahead.
So can you explain a little bit about how the technology has evolved since I got my implant, almost 20 years ago.
Okay, let's all go through the evolution of implants. I think it's very important to discuss. I started, so I'll go first. 1991, we placed our first implant.
Wow.
1991. We took a fellowship, so it was a 2-year fellowship. We learned how to do things in a very gross way, meaning expansion and with no technology. As the years have gone on, the precision of the implant placement has been much more and more precise. The digital analysis of the bone has been very precise. So we're in a very precise network of microns to get these implants made. So for me, the technology has been more of a precision-based and more technologically based to be able to get a really good implant in the perfect spot and when not to do the implant, knowing when not to do the
You
implant.
actually did, when you did the 3D scan on me for
Yeah.
my veneers, my
Yes.
smile makeover, I was actually thinking, like, wow, they should have had this back then when I was
Oh,
getting
boy.
my implant.
Well, a basic X-ray, CBCT, we didn't have. We
Oh,
didn't have
yeah,
that. It was a
it's
two-dimensional
wild.
X-ray. So
We would have to refer patients to go
Get a
to
medical
a
grade.
center and get that.
But yeah.
Or there was even a mobile van
the
that
amount of
had a
radiation
CT
from that is
machine,
a
and
lot.
that CT machine
Radiation.
would come in.
okay,
So
what
it's
was
really
your experience?
revolutionized.
I started placing my implants back in 2012, actually a little bit before 2012 when I was in my GPR at St. Barnabas. But from there, we started using CT scans for every surgery. So I've seen some oral surgeons that just take a Panorex, which is a two-dimensional image, and place implants that way. Not the best case scenario. But anyways, we started out with wax ups, dentures, especially if it's a full arch, and using that to help plan where the implants need to go and where the ideal tooth position are.
What have you seen the changes?
Yes.
Again, I started placing that same way with pano and just a panoramic and looking and touching the bone to place the implant. But what I realized that I wasn't giving the best position for the patient to receive that implant. And what I started doing little by little, I tapped into digital and digital dentistry, CBCT scans of the intraoral mouth. I started to create a digital avatar where I said, hey, if I could just easily plan my implant to go into one spot and I don't have to worry about it, and I could do that without even doing a clinical exploration or surgical exploration, I'm better prepared before I go into the practice, into the mouth. Patients that tell me, doc, but you did it in 5 minutes, you got my implants in. Like, yes, but I just spent an hour and a half, 2 hours reviewing the CT scan and planning everything.
And,
So the homework I do before I go into do the implant is what allows me to do that implant in 5 minutes,
Yeah.
to
And-
give the
Great
patient
point.
experience.
And just a reference point. In 1995, our implants used to take 2 hours, one implant. 2 hours. Today, it takes 5 to 7 minutes to put it in because we're doing the planning beforehand.
Now it's
And that's really the key, is to have that technology. If you don't have the technology, you're back into the 1 hour mode,
1 hour.
right? It takes you an hour to put 2 implants in. That's way too long for the mouth to be open, which also decreases the pain. If I can get in and out in 7 minutes, 8
Right.
minutes, you want to be open for 7 minutes or
Yeah.
you want to be open for 2 hours.
Yeah.
Yeah.
So there's going to be more pain when you're opened up, your jaw's opened up for 2 hours than for 7 minutes. So that's the big change, is the efficiency of knowing I'm going right in and getting right out, and the patient's out of there in 5-10 minutes. It takes longer to set up the room.
It does. It
It
But
does.
takes
to
15, 20
sanitize
minutes.
it.
You
to
could
set
you
up
could you
the
could see
surgical room.
yeah, you could see the eyes in my assistant's face, like the look. They're like, doc, I just spent an hour fixing the roof
Yeah.
and you go in 5
And
minutes.
you're done.
It's like,
You're
yeah.
in and out. Yeah.
Do you remember when you took my crown out
Yeah.
for my smile makeover? You looked at the implant and you said, "Oh wow, I helped develop this patent in 1994."
That's true.
I was so
Yeah,
impressed.
that's
I'm
true.
like, "Gosh,
Yeah,
she's
we-
really the best."
It's really crazy to know like where we started with implants. There was
Yeah.
only 3 companies in 1991.
Wow.
Now there's over 58 companies
Yeah.
on implant dentistry. I was at that real critical development stage of different companies. I just was on that team, and I was
Yeah.
young. I was 32 years old, and I was on this team of 65-year-olds and 55-year-olds who were way ahead of me. But I had such a good aesthetic eye that they didn't have, and they appreciated that. I had a digital technology that they didn't have. They appreciated that. So everything we were doing, we were all kind of helping the
Right.
companies and helping the profession move into this way of let's make it better.
Right.
Let's do it easier. Let's teach it to all our dentists. We were in this giving,
Yeah.
creative mode.
Yeah.
And that's how we came up with all these different types of implants. Even up to the point of 10 years ago, we developed a whole new system of scanning. I mean, that was a big part of 10 years ago, the scanning. Nobody was doing that.
Yeah.
So for me, it's been a wild ride of like the wild, wild west
Yeah.
to now to like stratosphere and digital avatars and all that. So I've seen that whole gamut. To me, it's incredible.
Wow.
Yeah, if you look at it, even in cardiology, like they used to be more hands-on doing surgery. Now they have robots doing it.
Right.
You know, the
right.
doctor's outside of the room and they're working with these robot arms and getting into and going very, very
Easy.
detailed to the
Less
spot.
invasive, more predictable, more efficient,
Precise, yeah.
Yeah.
and more precise, and all technology.
And that's where you asked me where I started, where I am now, and where I see for the future. I will definitely be placing implants with a robot.
Yeah.
You know,
Wow.
100%.
just to be
That's
so
really cool.
precise.
100%.
Because I
By the way,
know-
we tested the first robot
On
6
me?
years
Oh,
ago.
'cause-
6 years ago, we tested the first robot. It's a little bit big and cumbersome, but eventually it'll
Wow.
get there. Yeah,
Yeah.
we were the first office to have
Wow.
Yeah.
There are robots that are fully automated robots, and there's some robots or technology that's kind of like a GPS for
Assisted,
implants.
yeah.
So it's assisted. So your arm goes, you guide it,
my
but it
gosh.
kind of will nudge you to tell you where you need to go.
We should do an episode on that.
it. No, we don't want to do that.
We'll do a live implant with a robot on the next episode 8.
That setup is like an hour,
Yeah.
and that costs $200,000.
Oh yeah, I'm sure that's
So it's
very,
not practical. It's not practical. Not
Yeah,
yet.
the tech- the
it'll
cost
That's why I
of
said
this
not yet.
technology-
No, not yet. It's gonna get down to 10,000.
The cost of this technology is probably
Yeah, it's gonna get
Yeah.
get down to
Astronomical.
10,000, and then everybody's gonna buy it. But
Yeah.
it's not there yet. Believe
Yeah.
me, I'll let you know when it's ready.
please do.
I keep calling him. You down to 10,000 yet? Nope.
It's not going to go to 10,000. It's not going to
One
go.
day.
Yes, I think it will.
Yeah. It's 180
Look
right
what happened
now.
with scanners.
Down at 180.
It's
Okay, it was
180 right
250,
now.
Now it's 180.
How much is your microscope?
Microscopes go between 10,000 and 60,000. Mine's about 30,000.
Okay.
That's a big.
That's a nice one.
microscope is a big deal.
That's the next level too.
Microscope technology for implant dentistry and preparation and provisionalization. To be able to look under a 45 power microscope to place my implant is amazing to see what I'm seeing down there. So microscope is the next thing in dentistry. I believe in the next 5 years, 50% of the offices will have microscopes. That's my prediction, especially if I'm pushing it.
I love ours. I love seeing the videos.
Right?
It's cool.
Thank you for joining us on Talking Teeth. Our next episode will be very soon. I'm not sure when. Next month. And we appreciate everything. Thank you, Quinn. You're the best.